Hi, my name is Miranda Zygmunt, and for this SNAPPS presentation, I'm going to be presenting on a patient named Tom. So Tom is a 65-year-old male who presents with right shoulder pain and stiffness. The pain came on about 2 months ago and it has been getting progressively worse over the past 2 months. The patient does have a past medical history of a FOOSH on the right arm, as well as type 2 diabetes mellitus. He finds that he's most limited in his ability to reach up above his head like he's going into a cabinet, washing his hair while he's in the shower, and reaching behind his back to tuck in his shirt. He finds that something that helps with the pain is ice, as well as taking Tylenol twice a day, and he finds that the most aggravating thing for his pain is trying to reach up above his head. Numerical pain rating scale for this patient currently is 0 out of 10 at rest, but he said the worst pain in the past week has been a 7 out of 10. The patient is retired and he lives with his wife at home. His wife is in great physical health and is able to help him with any of the tasks that he cannot do. The patient does like to paint as a hobby, and he finds that he's limited right now in his ability to work in his studio with his shoulder pain and mobility issues. The goal of this patient ultimately is to be able to reach up into the cabinets in his kitchen so he can cook. He wants to be able to wash his hair while he's in the shower, and he wants to be able to be independent in dressing himself by being able to tuck in his shirt. My exam findings for the celiac exam included both passive and active limitations in range of motion. So with passive and active shoulder flexion and abduction, there was deficits. I also found that the greatest loss for range of motion was external rotation followed by abduction and then internal rotation. His resisted tests were negative. When I performed joint mobility assessments, so joint mobilizations, posterior glide, inferior glide, and traction, the pain came on at about 50% of his range of motion. After that, I asked him if I can go further. He said yes, and I was able to get to 75% of his range before he asked me to stop because of the pain. When I took goniometer measurements, I got 0 to 40 degrees for the right shoulder for both flexion and abduction of the shoulder. His external rotation measurement was 0 to 20 degrees for his right shoulder, and his internal rotation was 0 to 45 degrees for his right shoulder. With these findings, I have come up with the PT diagnosis of shoulder pain and mobility deficits adhesive capsulitis. The diagnosis is consistent with the limited active and passive range of motion during the celiac exam, showing that both were limited, showed me that it was not just a muscle power deficit, which would have been the case if only the active were limited. He also had the capsular pattern of motion loss, which was greatest loss of external rotation followed by abduction and then internal rotation. His joint mobility assessments, which were the joint mob stretched articulations, were also limited, and the goniometer measurements for all motions were limited, which also aligned with the diagnosis of adhesive capsulitis. The exam also helped me to rule out the muscle power deficits because the resisted tests were negative. The patient history of the FOOSH on the right arm 3 months ago, as well as diabetes mellitus, aligned with both of those being risk factors for the secondary cause of adhesive capsulitis. I found for this patient that the tissue irritability was moderate because he reported no pain at rest, only pain with movements and primarily at the end ranges of movements. He also reported that this pain was increasing over the past 2 months. So I put him into the pre-freezing stage of adhesive capsulitis. For a plan for this patient, I want him to come to physical therapy twice a week for 3 weeks, and then we want to try to progress to once a week for the next 3 weeks after that. What we want to address primarily is his mobility deficits as well as his pain. So what I would do as his physical therapist is work on joint mobility, primarily through the use of joint mobilizations. So I would be doing the posterior, inferior, and traction joint mobilizations. I would do that for 3 minutes depending on his grade, and then I would do that for 1 minute 3 times depending on his grade, and then I would want to reassess his range of motion to determine if this treatment is working and he's gaining more mobility. I would also want to try to progress from the resting position to progression positions as he continues to improve with that range. I would also want to do manual stretches into flexion, abduction, internal and external rotation, And most importantly, I would want to teach him how to do these stretches at home. So for flexion, for example, if he's able to have a pulley at home, I would have him practice gaining that range into flexion with the pulley. If he can't do that, I can teach him how to do wall slides with his arm up the wall to increase the flexion. For abduction, he can use a stick or a cane to try to increase that range and stretch into abduction, or he can assist with his other arm. For external rotation, again, I would have him use a stick or a cane and really stretch into that external rotation position. And then for internal rotation, I would have him stretch into internal rotation with a towel behind his back. That would also really help address his concerns about not being able to reach behind his back to tuck in his shirt while also improving his range. I would teach the patient to do these for 30 seconds, progressing to 60 seconds as they become more tolerated, and I would want them to do this 3 times a day to be able to regain the mobility that he lost as well as decrease his pain. That is all that I have for you today on our patient Tom.